I always hear that mycosis fungoides stage 1A is a stage you can live with for a long life. What about stage 1B if the rashes are recurrent but controlled by light treatments, sunlight, and ointment? Good long-term outcomes?
In general, patients with stage 1A and 1B mycosis fungoides will live long, healthy lives. There is a small subset of patients that may undergo disease progression. It can be very difficult for us to predict who those patients are, but odds are in your favor that this will not be a life-limiting illness.
Does FMF always progress? Is there a progression rate? Is early stage stable disease possible?
So FMF, for those people who are not familiar, is a variant of mycosis fungoides, folliculotropic mycosis fungoides. So this is a histologic subset of disease that is considered in general to be more aggressive, but that doesn't mean that every patient that has this histology progresses. It's very hard to put a rate on progression because it depends on what stage you were diagnosed and things like that. There are definitely patients who have an indolent course and have a very good prognosis, and there are a subset of patients who do progress. So I would probably discuss with your dermatologist or oncologist who has more knowledge of your clinical scenario and your pathology to get a better sense.
I was diagnosed with MF stage 1B in April of 22. It was well controlled with NB-UVB acititrin. I'll get the correct pronunciation. Yet I keep hearing reoccurrences to be expected. Why is that? What causes patches to return? As I navigate reducing my treatment over time, how concerned should I be about reoccurrence? Does reoccurrence lead to progression? That last question, we hear that a lot, and how to determine what is going to progress and what isn't.
So mycosis fungoides is generally considered an incurable condition. And at the early stages, our major goal is to manage your symptoms. And therapies are going to be either skin-directed or oral to try to manage the skin rashes and any itching and discomfort that may be associated with them. And we are unable to get complete clearance typically, and patients often do experience recurrences. It's very difficult to determine, to assess how long you may stay clear with any given therapy. But what's going to be really important is just keeping your regular visits, because if you do develop new patches and plaques while you're on therapy, there are numerous other lines of therapy that can be considered. The risk of recurrence doesn't really correlate directly with the risk of progression, as far as the literature is able to show us. So our goal with early stage disease that does not appear to be progressing is to keep you comfortable.
I wanted to add to Dr. Goyle's point that with something that is oftentimes measured on a timeline of many years, where we understand this to be a chronic process, it really is so important to distinguish between the presence or recurrence of the actual lymphoma that we can see versus the significantly symptomatic presence of what we can see. And that is to say that some people, even after a certain treatment, may notice that there are minor areas of recurrent skin problems, rashes that we can visualize. But if they're not bothersome, then it doesn't always necessitate the urgent need to start a new treatment that can carry with it side effects and toxicities. We know we're really trying to make this a marathon instead of a sprint. Understand that we're trying to maximize quality of life of the patients we care for, while also keeping them safe from disease progressing to significantly symptomatic stages. So that's such an individualized conversation, but just wanted to make clear that we really try to parse out just the presence of the disease versus how it's actually affecting you as a person.
First-time diagnosis of mycosis fungoides, what would your advice be?
So my first piece of advice is that I want you to find a dermatologist that you get along with, that you like, because you're going to have a long relationship with them. You're going to need annual full body skin exams from now until forever. So that would be my first piece of advice. And that person can help you assemble the rest of your care team. Because if at some point you need an oncologist or a radiation oncologist, your dermatologist will be able to help you do that.
I'd also add that I recommend you find your community, and that may be here through the CLF. Kind of alludes to a comment I made earlier, where just caring for patients in practice with cutaneous lymphomas, I've just come to recognize sometimes how it can feel a little bit isolating because it's an uncommon condition with uncommon treatments, and it's chronic, as Dr. Goyle mentioned, where it's a lifelong process for many people. So finding support in your community, finding good, reliable information, it's really crucial, because if you are newly diagnosed and you jump onto Google, there's a lot of information. And as we all know, especially for conditions that are uncommon and for expertise, where expertise is less prominent, you can find a lot of misinformation out there. So really connect yourself with trusted sources. You can ask for leads from your dermatologist or hematologist. But I think the Cutaneous Lymphoma Foundation is obviously a wonderful place and a hub to center around as you move forward.
I've had MF for 28 to 30 years. I was in stage 1A for approximately 27 years, but the disease has recently gone into stage 1B with patches appearing on limbs, neck, and armpits. I'm 74 years old and wondering if I should start treating since the cancer is incurable and will come back.
So again, stage 1A and 1B are both early stage disease, but as we said before, anytime you have a change in your disease, increasing number of lesions, a change in what they look like, we do want you to get reevaluated and see if any additional blood work, any additional studies would be necessary. In the event that your doctor says that, yeah, it's just new patches on your skin, then the treatment decision would be whether or not they're bothering you.
Can a stage 1A CTCL MF diagnosis cause fatigue, exhaustion, or overall weaken the immune system?
So like we just talked about, there may be subtle weaknesses of the immune system, but most often patients with early stage disease do not have terrible immune compromise. We don't treat you guys like patients that are undergoing chemotherapy, that degree of immune compromise. There are a lot of reasons for fatigue, weakness, that range from just not getting enough sleep to having anemia to having a variety of other medical conditions. So if you're experiencing symptoms like that, I would encourage you to talk to your primary care doctor and to your dermatologist and oncologist and let them know you're having these symptoms. So if there's any additional workup for reversible causes of those symptoms that needs to be done, it can be done.
How does moisturizer help people with MF, and how often we should moisturize?
So moisturizing is that is a common question, and when the skin barrier is affected by dryness, that can cause and trigger more inflammation and result in flares of a variety of inflammatory skin conditions. Eczema gets worse with dry skin, so does psoriasis. Many patients during the wintertime, you can have flares of your eczema or psoriasis, and that also applies to Mycosis Fungoides, CTCL. So moisturizing is really, really important. We recommend definitely doing it at least once a day after a shower while you're still a little damp. As I mentioned, use a cream or an ointment. And then you may need to do it a second time of day if you live in a cold, kind of dry environment. And I know this is hard. There are some people, and I don't want to generalize, but some men, it's not part of their routine to put topicals on their skin. But once you have the diagnosis of Mycosis Fungoides, it is very helpful to pay attention to it and moisturize regularly.
For someone recently diagnosed with stage 1 MF, what are the key first steps to take? Certain doctors to see, baseline testing, etc. This is a pretty common question on who to see and when.
In the ideal situation, your dermatologist, who usually is the one who diagnoses it because it's based on a skin biopsy, if they have experience with it, then but in the ideal situation, we would recommend being referred to a specialty center to confirm the diagnosis. Mycosis fungoides, as Dr. Pinter-Brown alluded to, sometimes on the biopsy can overlap or mimic other conditions. So you want just confirmation of the diagnosis by an expert who also examines your skin and does clinical pathologic correlation. They'll also examine your lymph nodes. That's an important part of the exam. Sometimes that's not done by a local dermatologist. There are some places where such a dermatologist doesn't exist, and there are oncologists, medical oncologists, like Dr. Pinter-Brown, who serves as also sees early stage patients. But as long as it's somebody who is familiar with and an expert and up to date with the recommendations for staging and treatment. In my clinic, early stage disease, we keep it pretty simple in terms of the staging. So if you have patches or plaques less than 10% of your body, and we do not feel any abnormally enlarged lymph nodes when we examine you, and if you don't have those B symptoms that were mentioned, unexplained fevers, chills, drenching night sweats, severe progressive fatigue, total body itching, then I will order a basic blood panel of a complete blood count, a metabolic panel, and something called lactate dehydrogenase. We also sometimes order 2 viral tests, HIV and HTLV, not because they're the cause of Mycosis fungoides, but those are viruses that can sometimes cause rashes that mimic Mycosis fungoides. So it's good to rule those out. And then imaging is really not necessary for, the scenario I just described, unless we find something abnormal on blood work. Bone marrow biopsy also is really just not done for early stage patients unless we find abnormalities on the complete blood count. And then do you have to see an oncologist with early stage disease? If you see a dermatologist who is familiar and expert in CTCL, then it's not necessary.
I would really echo what you've said, and I will say for my colleagues that are hematologists, oncologists that aren't so experienced, that frequently I see early stage patients that have PET scans and bone marrow tests because that's what we're used to doing for other kinds of lymphoma, but it really isn't necessary here.
My doctor told me to think of early stage MF as a chronic rash versus cancer. Is this a good attitude to have, or do I need to be more vigilant and check my skin for any changes?
I would advocate for a balanced approach. So this is a cancer, a rare cancer, but it is true early stage disease does in many ways behave more like a chronic inflammatory condition. But there are things you have to look out for. So I would say that you want to have regular follow-up with your trusted doctor. You want to keep an eye on skin changes and take good care of it. But at the same time, it's different than advanced stage disease. So I would say that it's in between the two approaches is what I would do.
How much does stress impact MF?
I'll take this one. I think that what the patients tell us is that stress does have impact on MF in terms of times of flares. In terms of how we can look at that scientifically, that's a lot harder to say in terms of kind of comparing one person to the next in terms of their levels of stress. But those that have had MF for some time know and other sorts of cutaneous kind of lymphoproliferative disorders, particularly something like lymphomatoid papulosis or other sorts of things, notice when they have flares or something stressful happen that they can correlate it quite specifically.
For mycosis fungoides, what is a good way to resolve itching, especially at night?
So I think one thing to do is treat the primary, like do a treatment, like whether it be acitretin, phototherapy, method, and any treatment for MF should help with itch. But then we also have therapies that just treat itch. So they wouldn't necessarily treat the mycosis fungoides, but help with the symptoms, so it's not making your life miserable. And there's a lot of options there. I think usually the first thing people try are things like Benadryl, which you've probably heard of, or a prescription version of that called hydroxyzine. If that doesn't work, there are other things we can try, like gabapentin, which some people may be on for kind of pain or neuropathic pain, whether it be like sciatica. But this can also help with itch, especially at night. There's other over-the-counter lotions like Sarna lotion one can try, which is kind of is like the icy of icy hot and causes kind of a cooling sensation. You can put that in the fridge. There's lots of different tips and tricks and things to try and prescriptions your doctor can give. But ultimately, I'm hoping that if you get on a good treatment plan, that will get the itch better too.
How is remission determined with the skin in MF? Will our skin ever be clear or will it turn from red to brown? How about you for this, Dr. Girardi?
Yeah, this is another great question. So on one hand, it should be obvious if you're in remission because CTCL is something that's on the outside of your skin. And so if you're clear and a doctor who does a full body skin examination can confirm that, then that could be a clinical remission of the skin. But some patients will experience a hyperpigmentation even when lesions have resolved. So I think that the question is pointing to we see some brown discoloration, and this can be different in different types of pigmented skin. More common, the more baseline pigment you have, the more likely you are to experience pigmentation upon a resolution of a skin lesion of CTCL. So when we look closely, both doctors and patients, at whether a lesion is persisting, it's really about the erythema, redness, the scale, flakiness, the symptoms, itch or burning, and less so about the pigmentation. So if it looks like normal skin lines and the pigmentation is kind of fading slowly over time, then probably that lesion had resolved before even the pigmentation resolves. The pigmentation could be the last thing to go away. It kind of persists for a while, and that can be disconcerting, but not necessarily a marker of involvement. Now, a doctor can also do a skin biopsy of a pigmented lesion and see if there are any persistent CTCL cells within that area of pigmentation to do a histologic confirmation. But really, if everything's progressing nicely, I always tell patients, if we see nice flat brown spots and no longer see thickened red spots, then we're in a good place.
Can mycosis fungoides become Sézary syndrome if it progresses, and what distinguishes the two? Dr. Sethi, you want to take this one again? Take this
Yes,
one?
Sure. All right. So, yes, there are patients who do present with advanced disease, early on when they're diagnosed, but there are others who have had like more early stage disease and then progress to more advanced stage disease. Sézary syndrome is defined by, the presence of erythroderma, where more than 80% of the skin is involved by a red scaly rash. Along with that, there is blood involvement with Sézary cells. And then there could also be some lymph node involvement. That's what we call the triad, or the three things that we see with Sézary syndrome more commonly. So definitely that can happen. In the way to, more than distinction, I think the more way to see, to assess for Sézary syndrome is beyond the skin exam, is to check for blood involvement by flow cytometry, and also looking at some genetic studies in the blood.
If you have mycosis fungoides, at what point should you see a hematologist? We'll just assume that not everyone has access to a multidisciplinary clinic like you offer in Iowa. So if someone's seeing a dermatologist.
I think this is such a wonderful question. And I think it really illustrates the importance of a two-way street as far as communication relationship with your dermatologist. The line is not one that's drawn in the sand. It's not clear sometimes. There are sometimes overlapping skill sets between dermatologist and a hematologist oncologist. That's very variable depending on the familiarity of the dermatologist, their experience, and their own comfort level with administering a whole array of treatments. And so I think that conversation is one where, in general, we think about for patients who are having trouble controlling their symptoms or the extent of their skin lymphoma with more skin-directed therapies or light therapies, that we considered thinking about treatments that might involve either oral systemic agents or infusional IV systemic agents. And that's kind of where that gray area is between a dermatologist's comfort zone in administering especially systemic therapies, and where a hematologist's purview might begin. So I think it's always worth asking, and always worth wondering aloud with your team if you think you're struggling to have success with your current plan of skin-directed therapies, to inquire about what the next steps might be and whether it might be worth a referral.
Great. Dr. Liu, any last and final thoughts on that topic?
Yeah, I would absolutely echo that. I think, generally speaking, certainly of advanced stage 3, 4, certainly deserve hematology expertise. It gets a little bit grayer, depending upon, the early patch plaque stage when, if one has very localized 1A, probably in the head with a dermatologist is okay. But beyond the 1B, where there's 10% or more, that's where it depends really on their comfort of clinicians. Of course, if you're lucky to get to work with a fantastic hematologist like Dr. Mo, I bring them in for all sorts of things. So, but a lot of it really depends on your particular.
Yeah, and I would just say, always feel free to seek out second opinions at a cutaneous lymphoma multidisciplinary clinic, even if they aren't necessarily really close, that you would go routinely, but it's always great to get a second opinion from experts in the field who can then work collaboratively with your local physicians, and then you've got backup, right? So I think that's always a great approach, and hopefully no one's disease progresses and you don't need all of that stuff, but it's always peace of mind, I think.
Is it always necessary to do additional biopsies to confirm MF? Or can you proceed with treatment like the topical steroids and UVB therapy without additional biopsies?
I think this is a tricky question because it sort of depends on how confident you are with the diagnosis with that original biopsy. Sometimes right out the gate, the diagnosis is very clear. Sometimes it's a little bit unclear. And of course, I think confirming the diagnosis is always helpful for understanding future prognosis and management options. Some people do prefer the approach of treating empirically, meaning treating based on, the patient's symptoms with topical steroids and UVB therapy. Whereas others feel a little bit more comfortable knowing about a diagnosis and having a more definitive answer. Many times, unfortunately, though, we just are not able to get a very definitive biopsy, and you still have to treat the patient. I think any time where there's a question about whether cutaneous lymphoma truly is the diagnosis, and if there is still a secondary diagnosis being considered, for example, psoriasis or eczema, where other treatment options may be available, then in my opinion, it does make sense to continue doing biopsies to at least determine whether or not, we should be going down a separate treatment path.
Next question is how to prevent Mycosis fungoides flare-ups. Any cream recommendations? Dr. Rang?
Well, in my experience, it's a little bit challenging to prevent a flare-up. We're not sure even if there's specific things that tend to cause MF to flare up, and many patients may point to different things in their own life experiences that tend to bring out the lesions. I think first and foremost is, trying to do as best as you can with the treatment that was provided by your clinician. And if that's a topical steroid, topical nitrogen mustard, light therapy, just kind of being as consistent as possible with that. We mentioned earlier, moisturizing your skin in general kind of helps protect the skin barrier against any external things that might inflame your skin and bring the lesions out more. And if there's any issues or concerns that you've developed a little bit of an infection over broken areas of skin, we do know that staph bacteria on the skin can sort of trigger inflammation and cause MF lesions to worsen. So if anything, there's question of, does this look infected? That might be something to address to kind of prevent a flare-up. Beyond that, I don't necessarily recommend a specific cream other than, bland fragrance-free moisturizers in general, and of course, topical therapies.
Is there any evidence that the disease, and they have Mycosis fungoides, can be transmitted to the next generation?
Okay, so I can take a stab at that. So transmission, in a way, it's not a contagious disease. So in that way, it cannot be transmitted through physical or bodily contact. I assume the question may have been also in terms of being inherited. Now, there are different ways of how we inherit things. There are, for example, very strong mutations that people inherit, for example, from their parents, like in the BRCA mutations for breast cancer, where if this mutation is inherited, there is a very high risk of getting that cancer. And for cutaneous or actually any type of lymphoma, we don't have evidence that there are these strong mutations that have a very high risk that relatives or children of the patients affected will have the disease as well. However, we do know that patients where in their family other members are affected by lymphoma or other blood cancers, their risk is slightly higher than that of the normal population or people who do not have relatives who are affected by lymphoma or generally cancer to get a lymphoma and a cancer. So the answer is it's quite complex. There is no strong inheritance. However, the chances of relatives of patients with lymphoma to be diagnosed with a lymphoma later are slightly higher than that of somebody in whose family there is no history of lymphoma or cancer.
They have MF stage 1A, and how frequently should they get a PET scan? What symptoms would suggest the need for a PET scan?
Usually, and as a medical oncologist, I usually don't see patients with stage 1A very frequently, but usually the guidelines actually do not even recommend for a newly diagnosed patient with stage 1A disease based on their clinical appearance, physical exam, and a complete blood count, any imaging, unless there are some features that may suggest that there might be a higher stage involved. For example, an abnormal blood count or an abnormal physical exam where lymph nodes are noted. So oftentimes PET scans are not done commonly for patients with stage 1A disease, but clearly there are exceptions where there's a clinical suspicion and for the fact that other nodes, for example, or the blood, etc., would be involved. Usually for stage 1A patients, if they're confirmed stage 1A and the initial PET scan was negative, then they really don't have to be routinely repeated and monitored. And we would monitor just on physical exam and clinical behavior. If there are signs of progression or other concerning symptoms, there might be a time where we would restage, where we would repeat a PET CT. But I would say on routine in stage 1A, we don't serially monitor PET scans.
What symptoms can signify advancement from MF early patch stage to the next stage and beyond?
So things I have my patients watch out for who are early patch stage. If suddenly, say you had just a few patches on your body, but suddenly they are starting to spread to many different parts of the body, covering your entire skin, for example. If the individual patches are becoming from being very flat, or you don't feel anything on the surface, to suddenly becoming much thicker, where there's actually substance and texture under the skin, or growing actual tumor nodules off your skin, that could be a very strong indication that your disease is advancing. Plus, in general, since, as Dr. Bard mentioned earlier, this is a multi-compartment disease where disease can be in places that is not visible. For example, your blood, your lymph nodes, organs. If you're generally noticing symptoms like unexplained weight loss, fevers, you're feeling swollen lymph nodes under your arms or around your neck, for example, those might be indications that it's moved to other areas. I often recommend patients kind of just keep up with their annual screening evaluations with their primary care doctor, because blood tests can be helpful too. If, for example, you notice that your lymphocyte count is rising in your blood, that could be an indication that perhaps it's advanced now internally into the bloodstream. Dr. Ward, I don't know if you had anything else to add for signs to look out for.
Absolutely agree. Paying attention to the skin lesions and paying attention to your body. If something doesn't feel right and you develop symptoms, we call them often constitutional symptoms, such as unexplained weight loss, unexplained fevers, drenching night sweats, or just generally feeling unwell. That is certainly something to bring to the attention of your treating physician to see whether the disease has changed and how it's behaving.